man. He is one of our uh, pre-physician paramedics, I guess you'd say. You were a paramedic long before you were a doc, right, Doc?
Right. Yep.
And been an emergency room physician for years, a medical director for ambulance services such as Life Care in Weatherford, Shackford County. There's another one that you are, and I never can remember that other one. First response. I keep forgetting that one.
Yeah.
Over in the Midland area.
Right.
So, yeah. So you guys, it's always a pleasure. And this particular topic is one of the ones that we've had selected as an advisory council and as a committee to hit hard, because the National Registry has been hitting the operations type lectures very hard on the exams recently, and planning on doing more. And that includes, not just EMS ops, but hazmat, terrorism, multiple casualty incidents, triage, those type of things. So Dr. Phillips recently did the TIM stuff, which I have not posted yet. I saw you sent the test questions on that. I'll be working on getting that stuff up very soon for the renewals for that. And terrorism is a perfect topic for tonight. So I am going to mute my microphone and turn this over to you, sir.
Okay. Now, one thing that I do want you to kind of take from this, and whoever ends up talking about the hazmat stuff, there's one point in here that they made that they said has apparently recently changed about decontamination. And so when that comes up, I'll point it out, but I'm not sure that I necessarily agree with what they're saying is the most current recommendation about that, but we'll get to that in just a little bit. So I also sent to Jane earlier today one of the slides from here so that you can actually get the links to some resources. And one of them in particular is, I think, an excellent resource, and we'll cover those in just a little bit as well. So let's see if I can make this thing go forward. So here's kind of what we're going to cover, okay? And so just a little bit of everything. And then I do also have a little bonus in here, and we'll come to that in a little bit as well. And just consider that your little icing on the cake for the evening. So we live in interesting times, and we're having a lot of interesting events right now. Just think about 2020, and then just remember, anything that's a terrorist event will be an historic occasion, whether we want it to be or not. And it's also, and I heard this initially back in 2000, it's not a matter of if there's going to be a terrorist attack, it's a matter of when is it going to happen. And so we all have those things that unfortunately we're going to be faced with at some point. Now, this is the first resource, and this is actually where that bonus item comes from as well. Dr. Clunan is a now retired Army colonel. He actually started out as an enlisted Special Forces medic and was a Green Beret in his enlisted life, and then ended up going to medical school and coming back. I had the good fortune of meeting him. If you've ever read Black Hawk Down, he was actually the physician in charge of the triage and treatment area when that event occurred. So he has a lot of good insight. He was, when I met him, he was the dean for the Joint Special Operations Medical Training Center. So obviously a huge focus on terrorism through that particular setting as well. So he was kind enough to give me this information. And actually, this is a free book that he has put up that was apparently released in 2007. So it's somewhat older information, but it's still very relevant. And also it's relevant not just to the tactical world or to special forces. It's got some good points that will help anybody that is doing emergency medicine, whether it be pre-hospital or in the hospital. So we've got two definitions of terrorism. One of them is international terrorism, which is mostly going to be through foreign terrorist organizations or nations, which would then be classified as state-sponsored terrorism. But we're also seeing more and more domestic terrorism. And some of these may be political, sometimes it's religious, but these are people that are in our own backyard. And I took these definitions from FBI.gov. And so these are the standardized law enforcement definitions of what terrorism is. But it's basically some sort of an act that more than anything is trying to frighten people. That's really kind of the bottom line on these things, is that we want to frighten people to get them to comply. So we often think of it as group sponsored. However, more and more it's becoming the single actor that's doing this. It's a lone person. So if you think about the shootings at Fort Hood, the shootings at churches, generally these are just one person that is acting alone. And so, it's kind of changing the paradigm of what law enforcement and military thinks about terrorism. We still have those other major groups that we have to worry about, but these are becoming more and more isolated as well. And generally, both the domestic and the international extremists tend to recruit people through social media platforms and those sort of things. And unfortunately, I think that in some senses, the information explosion has made things much easier to disseminate. And so, yes, Chris, that book is actually a PDF. You can download it. Operationalmedicine.org has an entire library there of things that are free, that are online. For instance, they actually have the Air Force Special Operations protocols that you can look at. So yeah, it's got a lot of great information there. So our top priority, first off, and I actually spoke with Dr. Clunan about this, and he said that, this is the thing that he wants everybody, regardless of what their job is, to keep first and foremost is scene safety. Now, when I was in EMT school, Dr. Dighton Packard was my medical director, and he was at Baylor Medical Center. And the very first day, I'm 18, actually, I'm still 17. I hadn't turned 18 yet. And he said, okay, first off, I want you to understand that hero is just a different way to spell dead. And I do not want any of you guys to be a hero. Now, when I was in the Air Force, that got even further reinforced, because when we were doing indoctrination training, one of the things that we did was we went to an area where they had all of the Air Force members that had ever been awarded the Congressional Medal of Honor. They had little plaques and things about what they did to earn that award. And the lieutenant pointed out, if you notice, almost all of these people died obtaining that honor. So, once again, we don't want you to be a hero. We want you to do a good job. We want you to take care of people. And if you're dead, you cannot do that. So please, anytime that there's something like this, even just a routine call, please, scene safety has to be first and foremost. Now, in terrorism, the big reason is there are often secondary devices, and they are there for the rescuers, for the first responders, because they want to make them victims as well. And if you take them out of the fight, then that decreases the amount of resistance. So there's a lot of reasons for that, but just understand that in a terrorist event, they want you to be a victim as well. So the next question is, have all the actors or suspects been neutralized? Because you don't want to unwittingly walk into a line of fire somewhere that was not suspected. And then, are there special situations that require specialized equipment? Whether that is that there is a bomb somewhere or potentially another bomb and they need to actually clear that area. We have to think these things through, and we have to do these things in a controlled manner. Once again, you cannot run in and be a hero. And then the biggest one, especially for those of us that have been in fire service, is that building stable? Has there been structural damage or something where you should not go into that building because, once again, we don't want you to become another victim. If there's smoke, burning plastics creates cyanide, and it creates it very quickly, and sometimes with some of these newer plastics in very high concentrations. So be sure that you have the appropriate equipment and those sort of things. So let's talk about blast injuries for a little bit, actually quite a bit. First off, these often are packed with things such as nails, ball bearings, screws, things to maximize the damage. And additionally, they're taught to put these into confined spaces such as elevators, trains, buses, so that it maximizes the forces. It contains it in a smaller area so it doesn't spread out. There are primary and secondary injuries to these things. And then these are actually the different types of blast injuries that can happen from an explosion. There's a primary, secondary, tertiary. We're going to cover these in a lot more detail in just a second. Not a lot, but in more detail. So first off, this is the Beirut explosion. And what I want you to see is I want you to see the shock wave that comes out of this. So let me see if I can get this to play. Watch these buildings down here in the front. Okay, so that was a massive shock wave. Okay, now this is a controlled explosion out in the desert, obviously, but they're going to back the camera up and you can actually see the blast wave come towards them. Not that. Look at this next part. There. So you get a sense for how far away they were when they made that go away. Okay, so the primary blast injury, this is due to that blast front is the technical term. You can see it moving and there's a pressure there, and it's that pressure difference that causes the damage. If it's 15 to 50 PSI, over half of those people will have tympanic membrane perforation. So they're going to have blood coming out of their ears. If they have blood coming out of their ears or they can't hear you because of that, you need to think that they may have a lung injury as well. Now, that's typically 50 to 100 PSI, but it can sometimes be at lower levels as well. Blast lung, we'll talk a little bit about, but blast lung itself could be an hour talk alone. But you can also end up with bowel perforations. You can end up with air emboli. The blast lung is damage to the alveolar and parenchymal structures. You get hemorrhage, you get lacerations, and you get pneumothoraces. Now, this last point was something that I actually had not heard of before, but it is in the literature, and that is you can actually get a vagal nerve stimulation that will make them bradycardic and apneic for a brief period of time. It's not a prolonged sort of thing, but if it's in association with some of these other things, such as hemorrhage, especially if it tears an aorta or something, that can be alone fatal. So this is a CT scan. This was from a soldier that was exposed to a vehicle-borne blast, and this is about an hour afterwards. Now, what they've tagged as A, that's a pneumothorax, and it's bilateral, and that's actually a very large pneumothorax. And then what they've labeled B is actually a pulmonary contusion. So he's got bleeding into the lung, that's a bruise in his lung, and he's also collapsed both lungs. So he's going to end up with chest tubes on each side. And chances are he's probably going to end up on a ventilator because of that pulmonary contusion, because this is early on. This is going to get worse. So y'all have any questions about that primary blast injury? And actually, Marla, yeah, people do live through this. Obviously, you can see the CT scan on that soldier. He lived through this. It depends on how powerful the explosion is, and it depends on the distance. That's really the biggest thing, because this very quickly will dissipate. And, the people that took those videos in Beirut, they lived through it as well. So the pathophysiology for the vagal response is that when that shock wave hits, it stimulates a vagal nerve. And so if you stimulate your vagus, that causes a bradycardia. The vagus also innervates the diaphragm. And so it basically shocks that nerve for a little bit. And so everything just kind of stops for a little bit. Now, it's not a prolonged pause. We're not talking minutes or hours. We're talking, a few seconds. But imagine that you're standing up on a wall somewhere and you get hit with the percussion, and that causes you to lose consciousness, and now you fall off of the wall. So now you've got another injury as a result of the blast that you would not have had otherwise. So it can cause a lot of problems. Anything else? It's a good question, Andrew. And I had to look it up. So, okay, we'll move on to secondary blast injuries. Now, this is actually what most folks think about. They think about the stuff that scatters out of this. So whether it's nails or pellets of some sort that they have put in there to cause more damage, those things. Also, though, if it's in an urban area, you're going to have glass and wood that's going to be thrown out. And I thought that this was interesting. Biological foreign bodies. So if it's a suicide bomber or another victim that's nearby, parts of their bone or other tissues may end up embedded in the patient, the other victim. And sometimes even bone or something from that victim can get re-embedded in another location on that same victim, depending on how they're standing or holding arms or things like that. The big thing is, if somebody has been in a blast, I don't care how small their wound appears, assume that there may be a foreign body in there. Because I have seen, thankfully we don't see it as much anymore, but from car accidents, when we used to have the safety glass in the side windows that would break into these cubes, you could see a very tiny laceration on somebody's arm. And if you felt of it, there you could feel a chunk of glass down in there. And you're like, how did that piece of glass get through that little hole? Well, it happens. And so the question is, the main thing is to recognize those things. And if possible, remove them, but that's not going to be something for you guys to do. Certainly, these folks are going to be monitored for infection and things like that. But it's more a matter of recognition. They have to be recognized, and you have to recognize, even in some cases, if it may be from a suicide bomber, that may be evidence. And so, there can be DNA that may be extracted from those pieces to be able to identify somebody, especially if it's a victim that you can't identify that person's body because it was so damaged. So there's a lot of other implications to this. For you guys, really the main thing is to recognize that these things can happen, because until we start getting field x-rays, I don't think that we're going to be diagnosing those things. Now, ultrasound, that's a whole other topic. So let's talk about a tertiary blast. So this is where your victim was close enough that the shock wave actually throws them against something or even the ground. And so it's that secondary thing. So the example where we had the soldier that was standing on a wall and the shock wave hits him and it results in him losing consciousness, and then he falls off of the wall. That would be a tertiary blast injury. And just keep in mind that this is primarily blunt trauma, but depending on what they hit or fall against, it may end up killing them or even causing amputations. And then when you just thought, okay, well, tertiary is plenty, now we have quaternary. blast injuries. And this is actually due to burns. So think about everything associated with burns, whether it's asphyxia because of carbon monoxide or from inhaling the heat and the flame, or actually having, if it's a bomb of some sort that has gasoline or something that is meant to catch on fire, obviously there can be things like that. Depending on if it's a dirty bomb or something, then there may be radiation exposure as well. And then they also throw in there the psychological effects. I've never been in an explosion. I don't want to be in one. But I can imagine that it is something that does cause some psychological trauma. So when you put all this stuff together, what you want to think about is this is multi-dimensional injuries. You get hurt from explosions, from a lot of different things. And so that's really what we want you to take away from this, is that there are multiple mechanisms of injury related to blast that needs to be thought about and taken care of. And I'll tell you that by far the thing that is potentially the most life-saving is recognizing if there may be a blast injury to the lung and to the heart. Those are really the big things, because those are things that somebody might just, oh, I feel fine of coughing a little bit, and then it proceeds to develop more and more into fulminant pulmonary edema, or they develop a tension pneumothorax. So these are the sort of things that we need to think about and have a high index of suspicion if there is an explosion. So anything about blast injuries before we move on? We're just kind of skimming the surface of this. Understand that probably each one of these things could be an hour in itself, and sometimes even more.
I had a quick question.
Sure.
Coming from a combat medic, they teach heavily tourniquets for major limb bleeds, mainly because you can't put one around the neck or a trunk yet. Is that still in practice in civilian use today?
Yes, it is. And we're going to come to that in just a little bit.
Gotcha.
But it's an excellent question. Thank you.
I also have a question.
And it sounds like my water may be starting to come back on. So
If you have a patient that has an impaled object, but that object is also contaminated with, like, if it's like some byproduct or something, how do you go like addressing that?
well, first off, from a field perspective, you're going to want to leave any impaled object there if you can. Okay.
Right.
There's going to be times that you can't, but for the most part, you just need to leave it there, recognize what it is, be sure and point it out, because those things really should be removed surgically. And okay, a surgeon may not necessarily take it to the OR, but they should be the ones to take those things out. And then we're going to automatically, with something like that, they will get antibiotics as soon as they hit the door. It's just going to happen.
Okay, but like, say the impaled object is contaminated with like some like hazmat spill, how do you go about like ensuring that you're not going to be affected as a provider?
That's actually a question that is going to be best left to the hazmat people, because they're not going to necessarily let you take those people until they are not going to be a danger to somebody else. And we'll come to the hazmat part of that stuff in a little bit as well.
All right.
So the penetrating object is hot. I'm assuming that you mean heat hot and not radiation hot. Once again, always stop the burning process. Put the wet stuff on the red stuff. So that's really the big thing. Things like that typically are not going to continue to be red hot for a long time. But obviously, if it's something where it's not in deep or something like that, it's probably going to come out pretty quickly, especially because if the patient is at all awake, they're going to reach up and pull the thing out. But the main thing is same thing that if somebody has, burning clothes on, you put the wet stuff on the red stuff and put it out.
Okay.
But good question. Okay. Anything else? There's obviously overlap in some of these different areas, so we'll get to everything. So penetrating trauma. Now, keep in mind, we're talking about terrorism specifically, okay? And of course, Britain has had a big problem with knives and stabbings because they don't allow handguns. They just are not there. And so, the terrorists in those cases tend to use very large knives, and it's not just one time and they run away. They stab them over and over and over. And most of the time it's to the upper body. It's not primarily to lower legs. They don't run up and stab them and from below and then run off. They're stabbing them to try to make a point and to make it as dramatically as possible. They also point out that with firearms, terrorists tend to prefer a semi-automatic because it has a higher fire rate, and also because the magazine can hold more than 5 to 6 rounds like your typical revolver would. So those are usually what they want to go to. I'm not getting into the gun control sort of thing, just stating the facts. Now, this is one I hadn't actually heard this acronym before, TARMAC, Targeted Automobile Ramming Mass Casualty Attacks. So I think somebody probably took a little while and found to come up with that particular acronym. But obviously the size and weight of the vehicle is a big factor, the speed that it's going, and then what part of the victim is hit. If they run over a leg versus if they hit their head with the bumper, obviously causes different things. It's going to be blunt trauma. This is, what we do day in and day out is blunt trauma when we talk about trauma, car accidents and those sort of things. Most of us don't do a bunch of penetrating trauma. So, really for the most part, even if it is because somebody drove a car into a crowd of people, it's still our bread and butter, day in, day out, blunt trauma. So yeah, it's horrible. There's a lot of people, those sort of things, but really the approach is the same as it would be any other time that you have a blunt traumatic injury. So chemical. So there's a lot of different agents in chemical attacks. First off, organophosphates or anything similar to that. Now, we primarily think about insecticides because those are things that a terrorist can get. They can stockpile those. They can go to farm and ranch supplies, and they can get these things fairly easily, and they are very potent. Certainly, though, we also would include in that similar vein some of the nerve agents, which are going to be difficult to get, but are much more potent as well. And the treatment is very much the same. It's giving them something for spasm and atropine, and then more atropine, and a lot more atropine. And then you keep giving some more atropine until you can get them the ultimate antidote, which is 2-PAM or prelidoxine. So, once again, it's an easy approach. It's the same as you would do if you're out in a rural area and a farmer got into some insecticide accidentally and starts showing signs of organophosphate poisoning. Irritants. So chlorine and ammonia are two of the big irritants that we see because they're used in farming. So Chris, when you say Wake County encouraged us to contact the large animal vet, was that because they had bigger vials of atropine? Yeah. So it would be, I would actually say that for most ground ambulance in the United States, you're not going to have enough atropine in one truck to take care of one person. You're really going to need a lot more. And probably even most hospitals are not going to have enough to take care of more than a couple of patients. But yeah, I actually hadn't heard that before, but it makes a lot of sense. So cow atropine. Um, so asphyxiants, and these can be a lot of different things, but basically asphyxiants of any sort are things that displace oxygen. So it can be carbon monoxide, it can be carbon dioxide, it can be helium. Any of the inert gases are sometimes used for these sort of purposes as well. Hydrogen sulfide, those are all things that can cause that. And then they also bring up vesicants. These are more historical. Frankly, we're talking about things like mustard gas. I believe that Saddam Hussein did use some vesicants on his people back in the 80s when they were having the war with Iran and Iraq. But I don't believe that those have been used anywhere in the world in many years, if not decades. Yeah, I like that number 3 there. That's very true. And so again, this is a topic that if you went to a terrorism conference, just these alone is going to be at least an hour, if not 2 or 3 hours. And there are so many different agents that can be used and that can be produced. So, we just kind of hit on the highlights here. So Chris, you say talk about ricin. So, well, okay, you can make it from castor beans. It's not really easy to make from castor beans. It can be made, but keep in mind that you also risk getting it into yourself as well. So it has to be done properly. Ricin is an agent that I'd have to actually look up to see exactly how it works because I don't really remember exactly. But the most famous ricin poisoning was actually a Russian agent or a Russian that had defected. And another Russian agent came up and stabbed him in the back of the leg with a umbrella tip that had a ricin granule that was in it, and it ended up killing that defector. So that's probably the most famous of those, but I don't believe that ricin, other than state-sponsored stuff, has really been used. And then it's been a specified sort of thing. It's not really something that even the terrorism experts would think is something that would be used on large gatherings, but usually more as a targeted attack on one person. If you have pulmonary edema, regardless of what it is, I think that all of us in emergency medicine and critical care are probably going to be talking, rather than CPAP, we're going to be talking about having them on a ventilator. And obviously we would have pressure with that, pressure support and PEEP. So I don't think that we would be putting them onto a CPAP or a BiPAP primarily. I think if they're that far down that they're bringing up pink frothy stuff, we're going to end up just saying we got to control their airway. But it's a good question. I think that for us in pre-hospital, I don't think that it's necessarily a bad thing to do. I actually, when we first got CPAP, we used a thing called a Busniak valve CPAP. And so it's actually an open CPAP, just a small valve that goes onto an anesthesia mask that came with straps to hold the mask in place. And I actually advocated using that as your pre-oxygenation before you do an intubation, so that we can try to get a little more time for them to not become hypoxic. And then you've got a mask that actually will fit right on a BVM that you just flop off to one side, and if you need it, you just swing it back over. So I think that CPAP using, and this is obviously not going to be on an exam, but I think that using CPAP or BiPAP to try to avoid intubating someone, but then using it to hyperoxygenate is probably a good thing. I think it's a good tactic. So, but that's a good question, Andrew. So, biological agents, okay, and actually ricin probably fits more as a biological agent. It's actually a toxin rather than it being an infection. And things like botulism that you see down there, that's actually a toxin as well. But keep in mind that biological agents, you can infect large numbers of people. The best way to get an effect is by airborne spread rather than it being person to person. So the thought of, smallpox, which, historically was on blankets that we gave to some of the Native Americans, that sort of contact and spread is not as effective as airborne spread. Some have threatened to contaminate food and water supplies, primarily water supplies, but just you guys are probably too young to remember for the most part. But if you think back to the 80s, all of a sudden that Tylenol got cyanide in it, and it killed a few people. And look at all the changes that were made because of that one incident. That's where we suddenly have all these, seals on everything, and everything is taped shut. And if there's tampering, just send it back or take it. Don't take that one. So there's a lot of things that happened as a result of the Tylenol scandal, for lack of a better term, involving cyanide. So, these are things that, you can sometimes contaminate something such as a medication and end up causing some mass panic. So, and you probably do remember back to 2001 anthrax, when they were sending white powder that everyone was afraid was anthrax, and some of it was through the mail to people in DC and other government officials. So those are some things that are out there as possibilities. And probably you guys don't remember with 9/11, some of us were actually asked to revaccinate for smallpox, because the theory was that that may actually be something that somebody would be able to get a hold of from Russia and be able to then start giving people smallpox again, even though technically it doesn't exist anymore except in a laboratory setting. I actually got revaccinated for smallpox. So. Any questions up to this point? Well, okay, so Kristen, it depends on what it is. Okay, obviously oxygen is always going to be a good choice, but as far as an antidote, there generally is not an inhaled antidote. If it is something like chlorine or ammonia, then you got to get them out of that environment and you have to start giving them oxygen. But you also have to assume that they're going to start having a lot of pulmonary edema and things that are associated with the fact that it's just an irritant to the airways. You can give them, nebulizer treatments are not going to necessarily be contraindicated. Chances are, if they have a significant exposure in most of those cases to those sort of things, irritants, it's not going to help that much because they're going to be producing so much in the way of secretions. If it's cyanide, if for some reason they were exposed to cyanide for whatever reason, such as a firefighter, firefighters are exposed to that all the time in the smoke. But if they're exposed to that, then obviously the treatment has to be begun early, and it's aggressive treatment with whatever you have. But the most effective treatment for cyanide is actually hydroxycobalamin. That's a vitamin, but you have to have an IV form of it. So let's see. Long-term viability in smallpox and cadavers. Well, I think that he probably disagrees with some of the folks that are, um, way up there in their area. I certainly have no idea about, the viability of smallpox in cadavers. Um, so it's a good question. Perhaps we should turn attention to some of those sort of things. Um, I honestly don't know, but it's a good question, Andrew. Anything else? Okay, so nuclear terrorism. So, this is one of those things that we've been afraid of. And, of course, we're always worried about some, lone dictator somewhere getting his hand on a nuclear weapon, but that's not very likely. More likely is that they're going to have something that they can contaminate another bomb with that also then releases some radiation. But the question is always, what type of radiation is it? And yeah, nuclear facility doesn't mean nuclear plants, but those are by far an area where they're going to have the most radioactive material as far as amount available. May not necessarily be that effective for their purposes other than for a dirty bomb. Once again, think about the fact that for most terrorism, it is not the number that they are impressed with. What they want is they want to strike fear in the people that are not affected. So, that's why they say, takeover of a nuclear facility is one of those things where, you just the fact that they have taken it over sends waves of fear. And then the concern would be, are they going to do something where they can turn it into a Chernobyl? So, or the Fukushima plant. I don't know if I said that one right, in Japan. Yeah. And so, Chris, my guess would be that probably those places that you're talking about are, first off, not very well known. They probably don't have a lot of high level radiation materials there. And if they do, especially if it's like a research facility of some sort, then those places probably are very heavily guarded. Once again, are they going to be more heavily guarded than a nuclear plant? Probably not. But, once again, that's a place probably more for them to obtain the materials to make a dirty bomb. See, I have no idea what those places even were. But yeah, so, once again, I think that those are more places where they would obtain materials for a dirty bomb more than they would anything else. And once again, it's not about the number of people that they kill. It's about the fear that they strike into those people. And then, as you see there, really, it was not the radiation that killed the people in Hiroshima and Nagasaki. It was actually all those things that we talked about with the blast injuries. And then, of course, later on, marrow suppression, GI tract damage, and long-term cancers. Those are things, you're going to have to wait 20, 30 years before you're going to see some of those things. So they're not in it for that. They are looking for an opportunity to strike fear and do it quickly. So before we move on to zones of care, any questions about any of the stuff up to this point? So when we start talking about zones of care, this is something that if you are in the tactical medicine world, or if you're in law enforcement, those sort of things, this is actually something that is very common to them. And we really probably, along with incident command, we probably need to start practicing some of these things anyway, so that we can try to get used to the terminology and get used to the changing of the protocols between these different areas. But You have the hot zone, which is the area closest to the event. And this is an area where they call it the non-permissive area. We're not going to let people in there unless they absolutely positively have to be there and we know exactly who it is. So these are areas where it is dangerous. So consider this as an area where there may be a secondary device, there may be another attacker that may be in hiding, waiting for an opportunity to take out first responders. So this is an area that is dangerous. The warm zone. Now this is the next level out. This is semi-permissive, but there can still be some dangers, whether it's, a stray bullet going somewhere, a blast effect that reaches out of the hot zone and into the warm zone. But this is the next level of protection. And then we have the cold zone, which is an area where it's basically there's not really any danger from the scene at that point. It's a matter of this is a place where we can start talking about doing more extensive treatment and care. So we try to put triage either in the warm or the cold zones. I would prefer, if it's one of my crews, I want that to be in a cold zone. If possible, bring them out of that area so that they're no longer in danger as well as you're no longer in danger. Security. So secondary attacks are very common, and their goal is to turn you into a victim. And you have to be assured, if you're going into a scene, that it is safe before you go in. Please, that you've heard it said over and over. Those entering the hot zone have to have the right protective equipment, whether it's body armor, Kevlar helmets, level A suit, those sort of things. If it's in, say, in a shopping mall and sprinklers were activated, you got to think that there may be slipping. You may get electrocuted. So these are all things that you have to kind of keep in mind. And once again, be careful when you start talking about even entering these areas. Casualty collection should be outside of that potential secondary bomb or other attack sites. So care inside of the hot or the warm zone, especially the hot zone, those folks need to have special training. This is an acronym that I found: safety first, catastrophic hemorrhage care, and then finally the ABCs. So first thing is you have to be safe, then stop the bleed, and then the ABCs. So it's basic life support, life-saving procedures only. Open an airway and get them out, okay? Notice it's only open the airway. Doesn't say that you're doing any airway procedures other than lifting their jaw or opening their mouth. So in the warm zone, they talk about putting on tourniquets, some basic airway management, such as a nasopharyngeal airway or an oral airway, and needling the chest for a pneumothorax. There are some other protocols out there: the 3 echo protocol, enter, evaluate, and evacuate, threat, which is threat suppression, stop the shooting, hemorrhage control, rapid extrication, assessment, and transport. So, there's different protocols for these things. And if you end up on one of these teams where, people go into the warm zone or the hot zone, you need to know what the agencies that are responding, all of them, what they're going to be doing, and everyone needs to be on the same page. Cold zone, this is the safe place. This is where you can start doing things like RSI. You can do things that may take a little more time, splinting, things like that. Triage really should be done in the cold zone, and it needs to be by whatever protocol that you use, whether it's START or it's SALT or some other variation. There's, I think, every year or so a new one comes out, but it needs to be done in a uniform manner. So let's talk a little bit about the Israeli experience, because the Israeli Magen David is the name for their ambulance service. Their ambulance personnel have more experience with terrorist incidents than anybody. And they've developed a thing that they call save and run. And so the only things that they do at the scene is try to stop the bleeding and do some sort of airway control and needle decompression. That's it. They're going to load them into an ambulance, and they're going to take those severely injured people to a level 1 trauma center as soon as they can. And they frequently end up with those facilities overwhelmed, in which case then they end up having to take them to other hospitals. And guess what? They don't complain about getting those people. They do what they got to do, and then they get them stabilized so that they can transfer them. When I was writing this, I was just thinking to myself, oh my God, if they did something like that at level 3 trauma center, say in the Dallas-Fort Worth area, I can just imagine how everyone would be so upset. And then if they took them to one that wasn't a designated trauma center because they were overwhelmed, same thing. People would be going, what am I supposed to do with this? It takes being willing to take care of these people and understand that this is, once again, a historic occasion. Things that are not normal are happening. So any questions up to this point? Yeah, and Dakota, there are some places like that. There's actually 2 counties in Texas that don't have a hospital, they don't have a doctor's office, and they don't even have an EMS. So, yeah, they're especially frontier areas, they are like that. So, everyone has to kind of address their own setting. But yeah, I certainly understand that. So catastrophic hemorrhage. So obviously the first thing is direct pressure. Put something on and hold some pressure on it. If it's arterial bleeding, life-threatening arterial bleeding, put a tourniquet on. Okay, I've seen people come in with tourniquets when they have a stabbing or a gunshot wound that is nowhere near a major artery. You do have to know where those major arteries are, because you also want to be sure that you're putting the tourniquet on in the right place so that you can apply it properly. And there it is, must be properly applied to be able to get the effect that you want. They talk about using hemostatic agents with a tourniquet. I think that if you're going to use a hemostatic agent, especially for any arterial bleeding, it needs to be in conjunction with a tourniquet. It doesn't need to be one or the other. And I wasn't there, but I do know of a SWAT call out where one of the officers got shot in the lateral thigh, grazing type wound, entrance anterior, exit posterior, and minimal damage. I mean, very, through and through, without a lot of tissue destruction. And they decided that they were going to put the quick clot in there, and they had the tea bag type quick clot. So a bag that you're supposed to put the whole bag down in there and leave it there. They cut it open and poured the agent into it. So, know what you're using. And if you're going to use it the right way at the right time. That officer did not need to have the burns that he got as a result of the quick clot, because it was not an arterial type wound. If you are putting something like that on an extremity, elevate it, get gravity on your side. And the really big thing is, if you even suspect that there's a pelvic fracture, an open book, especially, if you do the pelvic rock and that hurts them, put a binder on their pelvis, put a sheet around them or one of the commercially available binders, and close that book. That helps to stop the bleeding inside of their pelvis. So just don't think about it, just do it, because if you put it on and they don't need it, it's not a big deal. That's easy. We take those off. But if you don't put one on and they start bleeding, then that can be a really bad thing. Chris, I don't believe that there's been any actual studies where they quantitated the problem. Is how do you actually do that ethically, especially in humans? And then the next would be, is it going to hurt? I mean, so many of these things that we do, the question should really be two-pronged. It should be, is it going to help? But then also, is it going to hurt? And that's also one of the things that we're going to come with this bonus in a little bit. I don't believe, Dakota, that anybody carries masked trousers anymore, and the only reason that I've seen them within the last 30 years has been for people that have bilateral femur fractures. We took them off of all of our trucks. They were just taking up space. And I think that for the most part, everybody that's an EMS medical director has basically said, get them out of my truck. I don't even want them there. So, I thought it was interesting because I saw more of them when I was a resident on my trauma service than at any time in my life. And about half of the time they were applied over clothing. So that meant that you were going to have to take them off to be able to do anything such as putting in a Foley catheter. So then when they were putting them on, most of the time it was for people that had bilateral femur fractures. So you'd take the mask trousers off and you would see the mid shaft femur all of a sudden jump up, and now they've got a joint where there wasn't a joint because they had to take it off to be able to get access to the patient. So I haven't seen one in a truck. I remember when we took them off of our trucks when I was first a medical director back in 2000. We said, just take them out. So, yeah, I remember, Jane, I remember very well doing those on each other when I was in basic EMT school. Yeah, it was kind of fun to watch people get a head rush when let them down a little bit too fast, and that was in people that were normal. But yeah, I'm glad that they're gone, actually.
Yeah, we just got rid of them within the last 6 months. We've been fighting to get them off of the state requirements for years.
Well, okay, I'm going to blame Jeff Jarvis and Gerard Troutman for that. They were leaders. They should have had that gone along. Okay, well, I was in that group a long time too. So, but yeah, so I won't give them all the blame. But yeah, you know how it is with bureaucrats. It takes forever. Yeah, and Dakota, that's actually, I forgot what it was. Somebody said something about, what have you used that most young people haven't ever even seen? And somebody put mask trousers for it was an EMS medical director's forum.
I can put them on. I can still put on a Thomas half ring with cravats.
I probably could. It might take me a while, but yeah, I remember doing that too. There's another thing. Do we still do traction splinting as a skill anymore?
Yes, it's still there. There's still a lot of discussion. It has not gone away out of the curriculums yet.
I remember.
We're still having to teach spinal boards and all these type of things as well. Yeah. They're not gone yet.
Well, I remember doing a trauma survey in Graham, and the surveyor said, well, where's your traction splint? And I said, we don't have one. If we really got to have one, we get one from EMS. Well, you can't do that. Okay, show me where it says that I have to have a traction splint. It just says a long leg splint. And I'm like, okay, so we're in compliance. I won that one. So, yeah, actually, Marla, I would tell you that if you talk to the orthopedic surgeons, more of them are going away from wanting traction splints on femur fractures because their feeling is that you can end up actually causing more damage to the blood vessels with those things because when they take them off, all of a sudden you get bayoneting of the bone, or as it loses its traction because it'll slide up on their leg, then all of a sudden you get this damage to the blood vessels and stuff. So for the most part, most of us are saying just, do a long leg splint and leave them that way so that it isn't going back and forth. You're not sawing into the blood vessels. So back to terrorism. If you're doing chemical stuff, chemical responses at all, you have to have the right protective equipment. Please, once again, hero is dead. Don't go into places where you're not sure if it's safe or not. Now, this is that point that I was telling you about. Some people are now advocating holding decontamination victims until they arrive at the hospital. So not doing on-scene decontamination of these people. And they're arguing that if the providers in the ambulance have the appropriate PPE, then just load them into the ambulance and let them resuscitate them and give antidotes on the way to the hospital, and then do the decontamination there. My days in the military just tell me that that's a bad idea, because now you're going to contaminate your hospital. But that's why I think that this is actually an excellent question for whoever does hazmat to get further clarification.
Well, my question on that too is, you have now totally contaminated the ambulance as well, which means it's out of service, because it's not easy to decon an ambulance.
Exactly.
What about your air ambulances? You're basically going to put those in a pit and bury them, because there's no way to decon them.
Yeah. So, like I said, I want some clarification from that. And I actually would like to talk to some hazmat people and see what their reasoning is, and if that's really the case. So, biological terrorism, especially after 2020, every one of us should be an expert at biological terrorism protection. Okay. Because we're dealing with something very similar every day since March of 2020. And so once again, it depends on how it's transmitted. Is it airborne? Is it contact? Those sort of things. And then some things you may need pre-exposure. So think the smallpox vaccine that some of us got in 2001, or post-exposure prophylaxis. So if we think that somebody may have been exposed to anthrax, then those people need to get post-exposure prophylaxis, even if you don't know if that's really what it was. So there's a lot more to it, and this is where your medical director has to be involved in these things, and they need to be up to date on this sort of information as well. Radiologic, well, just remember that for the most part, the protection is basically your same PPE. Okay. And then once again, zones of care are very important here. And so if things are contaminated, it's going to be checked with the Geiger counter, and then it has to be deconned appropriately. Clothing has to be double bagged. It ain't coming back to you more than likely. You have to wash face and other exposed skin with soap and water. And then sometimes they have to do an internal decontamination. Now, if you have not watched on HBO, they had a series, I think it was 9 parts, Chernobyl, and it was about the Chernobyl nuclear disaster. Y'all are probably too young to even remember it in some cases, or you weren't even born in 1986 when this occurred. But I think it's an excellent series for you to look at, because they show you the things that they did wrong. So as far as internal decontamination, Marla, I have no clue on that. That's going to be for the people that do the medical physicist sort of things. These are things that I am not going to try to answer, because it's going to be way beyond me. That's going to be for them in the hospital or at other facilities. So generally an x-ray department they have to be inspected by what's called a medical physicist on a regular basis, and they're concerned with radiation leaks and things like that. And so those would be the go-to people to ask about that. The other would be radiation oncologist, because they're going to understand those things a lot better than we ever will. I talk about medicine as being like a swimming pool. In my case, it's an Olympic swimming pool. It's very broad and it looks really neat from the sidelines. But then if I stand up in it, you realize that the water only comes up to my waist. I don't know very much about everything, but I do know a little bit about a lot, mostly enough to get in trouble. So the big thing is protecting yourself. Okay, this actually, in one of the files that I was looking at, this was the first thing that they said was stay aware of your surroundings, refrain from oversharing personal information. Frankly, yeah, there's stuff on my Facebook page that says that I'm an EMS medical director, but you're not going to find pictures of me wearing body armor. You're not going to find pictures of me with a whole bunch of my medics. because I want those things to be what I considered secure communications. Additionally, if you hear something, you need to say something. So, it's okay to call the local police and tell them these things. You don't want to, someday look at the paper and go, ooh, I heard about that 4 days ago before it happened. Those are the things that you don't want. So questions up to this point. We just kind of skim the surface of most of this stuff. Truly, we could do an hour, probably another 4 hours on this. So acid base versus alkaline base. First off, it's acid or base, and it's acid or alkaline. So an alkaline is always a base, okay? So the terminology just, and I'm not getting on to you, Dakota, it's just more a matter of, I want you, when you discuss these things with people, to have the proper terminology so that it sounds appropriate. So I assume that you're talking about contact with an acid or a base. In those cases, first off, you don't want to try to neutralize those, because all that you want to do is you want to dilute those. So dilution is a pollution, or the solution for pollution is one phrase. I actually don't really care for that much, but you don't want to go and say, okay, well, I think that he may have an acid on him, so I'm going to put sodium bicarbonate on it because that's an alkaline and that'll neutralize it. A lot of times those reactions are what we would call exothermic, which means that they produce heat. So, in those cases, the best thing that you can do is going to be to call 1-800-222-1222. That is a number for poison control across the entire United States and Canada, and it will get you to a regional poison center, and they can talk you through those things. It is actually in my protocols that anytime that my crews pick up an overdose, I don't care if it's Tylenol, I don't care if it's heroin, I want them every time to call poison control. So, and we can talk about why that is at another time, because we're already a little bit over, but just kind of think that. Meth labs, they are chemical weapons, whether they wanted to be or not, they are. So let's talk real briefly. These are the resources, and this is a slide that I actually sent to Jane so that you guys can actually have the actual links and everything. The first one there is dated because I don't think that it's been updated since probably 2003. So this is the bonus, and this is actually from Colonel Clunan's text, and this actually is some information from a Dr. Peter Rosen. And if you ever ask an emergency physician who wrote the Bible, they're going to tell you Peter Rosen, because he has been the editor of the most respected emergency medicine textbook since the profession was formed in the 70s. But this is specifically speaking about pre-hospital emergency personnel. And the quote is, "There's a pervasive theme in emergency care, one of action orientation, that is of specific technical intervention. Before addressing the individual procedures, the psychological basis underlying the performance of technical acts should be considered. We select for and demand an aggressive, action-oriented psychological profile in our personnel. The consequence of this is that the hardest task for any good paramedic, nurse, or emergency physician is to perform inaction. In other words, to do nothing and see what happens." And I would encourage you, I had several trainers throughout my career that have said, okay, you know what? We need to leave the ICU and let the nursing staff do what they need to do, and we can come back and see what happened. And it's basically, we need to stop piddling around with the patient. And so the rest of this, and this is the actual technical imperative, and this is a quote from Dr. Rosen: "If a procedure is taught, it will be used with a frequency greater than its indications. Further, every procedure has a cost that must be assessed as a complex therapeutic ratio. The deficit to the patient produced by not performing the procedure versus the deficit produced by performing the procedure improperly or performing it when it is unnecessary. So in other words, and I've seen it in myself, that if I learn something new, all of a sudden everything looks like a nail. If I only have a hammer, if I just got a hammer, I want to use that procedure in every situation that I can. But the problem is that sometimes we may cause more problems as a result of that. And so once again, one of the wisest things that I learned, and it was with Dr. Don James in the big city of Rolla, Missouri, was, okay, you know what? We need to get out of the ICU and we need to let the nurses do what they need to do. And that has been one of the best lessons that I've ever had. And at the same time, it is one of the hardest things for me to do sitting in an ER, is to walk away from a bedside and say, okay, call me if you need me. Because generally these are things that we need some time to see which way the patient's going to go. And yes, I think that to answer your question, Marla, especially endotracheal tubes, I believe that we probably in many cases overdo those things. And I know without a doubt, especially when I was a resident, that I was doing way too many of those. And when I came back and started working in Fort Worth, they were very dogmatic about less than 8 on the GCS, you got to intubate. And it got to the point where I actually earned a nickname. At the time, I was kind of proud of it, not so much now, from the ICU staff there. And the nickname was that they called me Sir Tubes a lot, because I would basically do an intubation pretty much every shift that I was there. Now I've kind of realized that I don't necessarily need to do all of those. And most of the time the patient does just fine. So a lot of that is age on my part. You know, I've had some time to learn these things and see that, hey, you know, it doesn't necessarily hinge on me. And so, yeah, I think it's more a matter of wisdom. Now, I would say gray hair, but well, you can't really see that. But you know, learning from, you know, multiple cases. So, you know, I would encourage you all to sometime sit back and go, okay, why am I really doing this particular procedure? You know, and yeah, probably even IVs to some extent. Any other questions? You can unmute, you can talk. It's okay. I know it's not that clear.
Well, I hear crickets, so I think it's time that we loaded this up for the night. Dr. Phillips, that was a fantastic lecture. We appreciate it very much.
Absolutely.
I'll get it posted as soon as possible. And, you know, you guys all out there, I hope you all stay safe and warm.
Yes.
Thank you. You
Absolutely.
as well. Thank you, Doctor.
You're welcome. Y'all have a good night.
Good night, everybody.
Bye-bye.